Hello and welcome to today's webinar. I'm Jim Rosenberger, Director of the National Institute of Statistical Sciences, and I'm pleased that NISS can host this 9th webinar in our joint COPSS-NISS series on COVID-19 related data science webinars. COPSS, the Committee of Presidents of Statistical Societies, includes ASA, ENAR, IMS, SC, and WENAR. I want to thank excuse the interruption. I want to thank Professor Shihong Lin, Chair of the Organizing Committee, and everyone who helped organize this series of webinars. And thanks to Glenn Johnson at NISS and Lingxiao Xu at Penn State and NISS, who provide technical and communication support for this series. Participants are all muted, but we encourage you to put your questions during the session into the Q&A box at the bottom of your Zoom screen. Today's webinar was organized and will be moderated by Karen Bandine Roche, Hurley Durer, Professor and Chair of Biostatistics at Johns Hopkins University, and a member of the Organizing Committee representing NISS, where she also serves on the board. She will introduce our speakers, Professor Scott Ziegler and Brian Garibaldi, and moderate the Q&A at the end of the webinar. I'll now turn this over to Karen. Please take it away.
Jim, thanks so much. So it's my great pleasure to be a part of this series and particularly to moderate this session, Flying the Plane While Improving It, Learning from COVID Patient Data in Close to Real Time. I think you're in for an amazing, inspiring story for what is possible when data science, health science, and medicine partner closely together. I've been privileged to be an insider observer in this effort. If the airplane analogy holds, you can think of me sort of as a flight attendant in the effort. I'm going to introduce both of our speakers in a moment, then I'll turn it over to them. I'll let them do their own mid-seminar handoffs. And we'll monitor for questions, certainly try to pick up any clarifying or highly important questions, but mostly deferring to the end where we be sure to reserve some time for discussion. Our first speaker, Brian Garibaldi, is Associate Professor of Medicine in the Division of Pulmonary and Critical Care Medicine, as well as the Director of the Biocontainment Unit at Johns Hopkins, as well as directing the Johns Hopkins Precision Medicine Center of Excellence for COVID-19. After we start, I'll put a link for that center into the chat. If you check it out, you'll see that Brian has led a prolific research effort around COVID. Amazingly, he's also an actively practicing clinician, as you'll hear, who's been out on the front lines of COVID care. More than once, he's appeared on our weekly Zoom meetings in full PPE from the ICU. Scott Ziegler then needs no introduction for, I think, most of you. Surely he's one of the world's eminent biostatisticians, and he's one of the most highly cited mathematical scientists in the world. Long preceding COVID, he became passionate about the need to improve healthcare value in the United States. And so he took on the mantle of leading the Precision Medicine Initiative as it was being founded throughout Johns Hopkins, and he continues to co-lead it. Here we call it individualized health, reflecting Scott's ethos. We're fortunate that thanks in a large part to his efforts, the infrastructure and practices for health system learning were in place when COVID hit, making the story that you're about to hear possible. And so in short, Brian and Scott together have led an initiative to learn from the Johns Hopkins COVID data and then to use the findings to improve clinical care in real time. Without further ado, I'll turn it over to Dr. Garibaldi first. Thank you so much for joining us today.
Well, thank you, Karen, for that wonderful introduction. And obviously, thank you for all of your work. And you're a really big part of this story, as we'll get to. A lot of what we're going to share today wouldn't have happened without your leadership and helping us put together the teams that we're going to discuss. And thanks for the invitation to be here today. Really, really excited to share our work. We will mention some specific COVID therapeutics like remdesivir and tocilizumab, but we do not have any disclosures related to these. I do consulting work for Janssen Research and Development, which is the company that manufactures the Johnson & Johnson vaccine, but we're not going to talk about vaccines directly today. So one disclosure, I was on the president's care team for COVID, And I can't share much of that story, but I will relate this. This is the picture from the first press conference. And I got a call from my mom right after this happened. She didn't know I was actually taking care of the president because we weren't supposed to tell anybody. And the only thing she had to say was, can you ask them to get a smaller microphone, because we couldn't take a good picture of you. And I went and talked to the media person at Walter Reed, and the next day they had a smaller microphone. So I thought I would share that little funny anecdote. So by the end of our time today, hopefully you'll understand the purpose and the process by which we created what we're calling the JH Crown Registry, which is our COVID registry. We're going to share some challenges that were encountered during putting together the registry, but also the methodologies that we use to try to answer specific COVID questions. We'll share some of the insights that we've gained from Crown. I think really highlighting how the combination or the collaborative efforts between clinical and data science has really improved COVID outcomes and really informs not just what we're doing for COVID, but I think what is going to change the way we think about big data moving forward. So my story or journey into infectious diseases started back in 2014, where if you remember, Thomas Duncan was a return traveler who was diagnosed with Ebola at a hospital in Dallas, Texas. And his diagnosis was initially missed, and several people got sick while caring for him. And so it became a huge imperative for all healthcare systems to figure out how they were going to handle both identifying and isolating, but also caring for patients who had viral hemorrhagic fevers. And this was my first training session where they put us in gear, they covered us up with paint, and then said, okay, now get out of this gear and see if you're covered with paint. And I just want to highlight in the back here, here's a box of, this was actually done, our training was done in the old chaplain's cafeteria. And so there's a box of Bibles behind us, which was sort of the environment of concern and uncertainty about potentially creating these types of environments to care for patients. And this effort led to us deciding that we needed to have a dedicated space or a dedicated unit. And so this is the layout of our Hopkins biocontainment unit, which was the first unit to care for COVID-19 patients in our health system. And that effort has since led to the organization of 10 regional treatment centers across the country, who initially were set up to deal with Ebola and viral hemorrhagic fevers. But we were also, before SARS-CoV-2 came about, we were also preparing to take care of the recurrence of SARS or MERS patients if they came to the United States in great numbers. And so once we learned about the existence of SARS-CoV-2, we knew that our units would be a call to action at some point in the near future. Our mission is really reflects the tripartite mission of Hopkins. So it's to provide outstanding patient care, to educate and train not just our staff, but staff around the state of Maryland and also across the country with our partners in the other regional treatment centers. And then also research and innovation to try to understand how to make the built environment safer, how to employ technology to care for patients more safely in this environment. And then obviously that research shifted towards COVID once COVID hit. So our unit activated for our first people under investigation back in February of 2020. And for the first month of our response at Hopkins, our unit was taking care of all the people under investigation and then all of the confirmed cases until we had to migrate to larger intensive care unit space, because our unit itself has 4 beds and we share a sister unit that has 8 beds. But very, very quickly, we had more than 12 patients in the hospital system. This was a picture that I'm not supposed to show anymore because none of us are wearing masks or social distancing. This was back in February, the night we activated for our first person under investigation. And this is the last time I was in the hospital not wearing a mask in the last year. So I wanted to share with you the story of our first patient to frame the types of questions that we honestly did not know how to answer at the time that he arrived to our hospital. And I have his permission to share this data. He was actually featured on CNN several times. So he's a 40-year-old male who had a 4-day history of fever and cough. He had recently gone to Florida on vacation with his family, where he was, at the beach, going out to clubs, playing basketball, had no problems, no difficulties, and really had no significant past medical history. As I'll show you pictures of him later, he's actually a high-level athlete who participates in Spartan runs and Tough Mudders and triathlons. And on his arrival to the emergency department, this was his chest x-ray. He had a high fever. He was breathing very fast. His heart rate was fast, and he required a lot of oxygen. in order to keep his oxygen levels in a normal range. And his x-ray shows bilateral patchy infiltrates, which are very consistent with COVID, but not specific to COVID. Excuse me. And shortly after this x-ray was taken, he was placed on a breathing machine and transferred to our hospital. And on his arrival, there were a lot of questions that were already forming about how to take care of these patients. So the timing of when to put somebody on a breathing machine continues to be a source of uncertainty for us. Whether or not we should be proning people like him, putting them on their belly while they're on the ventilator to try to improve their oxygenation. This was early on, this was early March of 2020, but there were already reports from France about the potential benefits of hydroxychloroquine. So should we put him on Plaquenil? Remdesivir, the studies had not yet been done, but it was available as an investigational drug from the FDA. So should we go to the FDA and request an exemption? There had already been people treated with steroids in China, but there was a lot of concern about what the impact of steroids would be on a viral infection and potentially suppressing the immune system. And then there are all other medications that could be tried: lopinavir and ritonavir, which is an HIV antiviral medication; tocilizumab, which is a rheumatoid arthritis drug that combats inflammation. And then even back in March of 2020, there are already reports emerging of people with aggressive or more common blood clots. And so should we put this patient on anticoagulation? And so his hospital course, he was on the breathing machine for 26 days. We ended up proning him multiple times. He was diagnosed with some heart dysfunction. He had a blood clot. He developed a secondary infection. He had a profound delirium, likely related to a combination of the COVID, but also the medications we had to give him to keep him safe on the breathing machine. And he also lost 50 pounds. His laboratory data raised even more questions than answers. He had a very elevated D-dimer, which is a marker of potential increased risk of clot. He had high inflammatory markers like a fibrinogen and a C-reactive protein and IL-6 level. And then he also was lymphopenic. He had a low lymphocyte count, which had been described in China for COVID, but the significance was still unclear. He also had these episodes here, shown here are his vital signs over time. And you can see here on the bottom, he would have these episodes of really high spiking fevers that were accompanied with this profound drive to breathe, lower oxygen levels, lower blood pressures, and high pulse. And this cyclical nature of these vital sign abnormalities was really what prompted some people to postulate that there was a hyperinflammatory state with COVID and that you'd cycle through these periods. But we didn't know if this was actually true. And we also didn't know how to treat these episodes when they happened. One way to think about how someone's progressing through their COVID hospitalization is to try to classify the severity of their disease. And this is one of many grading systems that have been proposed. This was the early one proposed by the WHO. And you can see here it goes from 0 means you're non-infected and you're an outpatient. 3 is you're hospitalized but not requiring oxygen. And all the way up to 7 are increasing levels of oxygen support, ranging from simple oxygen to being on a ventilator to being on extra organ support like an ECMO machine or perhaps dialysis or blood pressure medications. And unfortunately, 8 represents people who die from COVID. And this is what our patient's trajectory would look like if you mapped it out using that 8-point scale. So he comes in peach here, he's intubated on arrival. He did briefly for a day go on additional organ support. He had a prolonged time on the breathing machine. Here in light blue, he got taken off the breathing machine and put on high levels of oxygen through a nasal cannula. Then he was just on regular oxygen. Finally, he's on no oxygen, but still sick enough to be in the hospital. And then in green here, he gets discharged. And this is a picture of him before he got sick. And this is him 50 days later when he finally went home. He had lost about 50 pounds, had to relearn how to, just do basic activities of daily living. Thankfully, he has not suffered from long COVID. I spoke to him about a month ago. He's back to doing triathlons and feels better than he ever has because he's been fortunate. But right around this time when we were taking care of our first patients, Anthony Rosen, who's our Vice Dean of Research, he put together a team of scientists to start thinking about what questions should we start asking about COVID, about the clinical trajectories of patients, about the pathobiology of disease, about therapeutics. And so we put together these regular meetings that were happening two times a week initially. And, Scott was a part of those meetings with me. And, he invited me to be there because I was one of the first frontline clinicians at Hopkins. And we had a group of us who were taking care of these patients who would just share our bedside observations with the research team to inform their questions. And for 3 meetings in a row, Anthony asked me the same question. And it was, what is the relationship between a D-dimer level and your risk of being put on a breathing machine? And the third time that I answered him, well, I don't know, Anthony, I can't keep track of all the patients we're seeing now. We're up to 60 patients, and I just don't know. He says, well, you shouldn't have to know. You should have a data registry and a team of biostatisticians who can curate that data for you, and then we can come up with the questions and they can provide you with some answers, and then we can make decisions based on that. And I was like, well, that sounds like a lovely idea, Anthony, but it doesn't exist. And that was on a Friday afternoon. And Sunday evening that weekend, Anthony called me and said, I just completed the IRB application. I need you to take a look at it, add some clinical pieces to it. And by the next day, we actually had an expedited review and we had our registry approved. And we decided to use the precision medicine analytics platform. And Karen alluded to this. This is an approach to getting data together from multiple different sources, and then having the ability to apply lots of different methodologies and statistical applications in a secure environment to be able to learn from data quickly and to be able to make inferences and observations about individuals. And this led to us creating the JH Crown registry. And so JH Crown includes any patient across the Hopkins Health System who has a positive test for SARS-CoV-2 or a clinical diagnosis of COVID-19. But it also includes any patient who's tested for SARS-CoV-2. So at the very beginning of the outbreak, this meant that anyone who had a suspicion for COVID-19, you had characteristic symptoms, maybe you have a travel history, depending on when we were talking about this, you would get put into the registry because someone suspected that you have COVID. But over time, that's evolved into, wow, you're coming to Hopkins for any related medical visit, you're likely going to get a COVID test. The main source of the data is EPIC, which is our electronic health record. And that includes very detailed information on labs, medications, vital signs, clinical notes. But we also bring in radiology data and have the ability to link to physiologic monitoring data, the actual minute-to-minute cardiac monitoring, for example, that happens in the hospital. As we'll talk about a little bit later, the registry itself was built by a village. There's a whole host of people across the entire health system who obviously were involved in building PMAP in the first place, but also were tasked to help us with Crown. And as of early last week, we're now closer to about 6,500 COVID inpatients, about 25,000 COVID outpatients, and we're now close to 200,000 negative controls, which form the basis of the studies and methods that Scott's going to share with you. So I'm going to stop sharing here and invite Scott to jump in.
Okay, I'll share my screen. Thanks very much, Brian. And let's see. Bring this into full screen. Just take a second. So can you see that, Brian?
Yeah, you're great, Scott.
So, well, it's a pleasure to be here. And I say the real pleasure has been working with the team of 30 or 40 people that Brian will show some pictures of later. We had volunteers from across the clinical, clinicians, clinical scientists, and statisticians, people from the engineering school, people from around the campus. So it was wonderful. And what was exciting as a statistician was the fact that we were confronted every single meeting, every single effort involved returning to the substantive questions. And the main ones that the patients were asking the doctors and they were asking us is, how do we better indicate a patient's current disease state? And how does this patient compare to other patients? And what's the trajectory of the patient? Are they getting better? Are they getting worse? And then critically, among the available treatments, which one is the best treatment for this patient now? And there are two aspects to that third question. First is, on average, in our population of patients, how well does a particular treatment work for people like the person at hand? And then secondly, how heterogeneous are the treatment efficacy and safety for patients? So we've been working on many questions of which they're generically like this, but to address those questions, a whole series of statistical issues arise, and some of them have solutions, some of them we're working on solutions, as are many of our colleagues around the world. So the first thing that I want to stress is that to make progress, we had to spend probably 6 weeks, what I call wrangling the data. We had some superb IT people, but also some superb statisticians who understood about what we had to, how the data had to be organized to be able to make progress. And it was the data that's generated in the transactions of medicine are enormous and complex and convoluted. It's a lot of 80% text. And so we had to do a lot of work to get our hands on the variables we needed to do analysis. But right along the way, we were starting to think about the problem. So what were the unique statistical challenges? Well, the first thing is that this is a brand new disease. So there was almost no clinical evidence base. So when Brian listed the clinical questions he was concerned about as it regard to treatments, there just wasn't much of a clinical evidence base. So we were forced to try to learn what we could from observational data as we were compiling it and others were compiling it. And the aspect of COVID that's interesting is that treatments are tried, we see outcomes in real time, we change treatments, we see outcomes. And so there's this iterative process that goes on in the management of a COVID patient, which is, and in an observational setting makes statistical inference challenging. The outcomes that we were observing were a series of biomarkers like Brian showed you at the beginning, but also major events and major treatment choices. In this kind of a setting, the treatments themselves are outcomes that are influenced by the prior biomarker measures and events that have occurred. And so we have to model them jointly. It's a competing risks problem fundamentally, because as you observe people over time, you're interested in, for example, what's the probability of the person having severe disease in the next week? But in that period of time, they might also be discharged or they might die. And so these three major events, discharge, intubation, and death, change the whole setting and are competing with each other and need to be treated accordingly. There's a significant fraction of deaths, especially early on, maybe 10%, I think, Brian, something like that. And so we need to take account of that. And when we started, we had many hundreds of measures that we were making, any of which could have been important. In the end, we narrowed down to a smaller group, but at the beginning we had very large numbers of predictors, and they were dynamic predictors. Sorry, and they were changing through time. Many were irrelevant, but we needed to sort through them. And finally, it wasn't enough to learn something from the data and to then try to submit a paper someplace. We really had to get it back into clinical practice to be able to make a difference to the patients. So what I'm going to do now is take you through 3 or 4 examples that have some of these characteristics. I've chosen the examples to represent different statistical challenges. I'll show you briefly our solutions. I don't have one equation, I don't think. Some of you will be disappointed, others of you will be delighted. And I'm going to invite Brian to jump in and to add his interpretation where it would be helpful and get to keep me out of any trouble. So the first problem we're going to look at together is when we first started, patients were showing up. We were reading lots of things about what were the risk factors. There was a lot of things were true, some things turned out not to be true. And so we wanted to track our own experience about this. And so we wanted, when a person came into the hospital the very first day, to take a set of measurements on them and to have some idea about what their risks of having serious disease. So what we mean by serious disease, sorry, just one second. I should not touch my mouse. What we mean by serious disease is defined here. I won't go into that, but at the beginning, we didn't have a measure of serious disease, and so this had to emerge. We had to take account of the competing risks, as I described just a moment ago. We wanted to be able to predict severe outcomes from a large number of baseline variables, which may or may not have been important. And so what we did is we took some combination of clinical judgment. Brian and others said we have to have the following variables in our prediction equation, because if we don't, then we'll be asked for them, and why they're not there. And so we forced certain things into the models, and we used Lasso to predict the rest. And we built a COVID inpatient risk calculator, CIRC, which is available publicly now, and which was available very soon after our group started working. It took a long while to be published because the journals, this is sort of, was a little bit out of their realm, but they were very collaborative and cooperative. And I'm going to let Brian just describe this figure, but I just want to say that as a statistician, one of the amazing things about COVID is how varied the patient population risk is. So you have people who have very low risk and people who have very high risk, and there are variables that you could measure at baseline that distinguish these people. Brian, you want to jump in?
Yeah, so what this plot shows on the right here, this is the cumulative incidence of severe disease or death. And these are 6 actual patients from our data registry. And as Scott mentioned, you can see the wide variation in the risk of someone developing severe disease or death over the first 10 days of their hospital stay. And so just to illustrate that, if you look at figure F, he's a 39-year-old man with CCI as Charlson Comorbidity Index. So he has no chronic illnesses. He's not obese. And when he comes to the hospital, his respiratory rates may be a touch elevated, but he has no fever. And so his risk of developing severe disease or death, in this case, going to the ICU, requiring high levels of oxygen, is very, very low. And in marked contrast, patient A is an 81-year-old who has diabetes and hypertension, is obese. And when she shows up on arrival to the hospital, she already has an elevated respiratory rate. She has a high fever and she has elevated inflammatory markers. And her risk of developing severe disease or death over the course of her hospital stay is very, very elevated. And this is the type of, we wanted to try to begin to explain what underlies this heterogeneity in risk of severe illness.
Thank you. And now this tool is available. What's the group that's distributing this, Brian?
So we're hopefully going to have this on MD Calc, which is the like world leader in medical calculator devices. But we're trying to switch the codes and make it in a language that they use on their site. So we're almost there.
And to get these cumulative incidence curves, you need to take account of the fact that people who are leaving because they're going home aren't censored, right? They're not censored like they would be in an uninformative censoring setting, but are in fact the healthiest people among our population. So those sorts of adjustments have to be made for these curves to be valid. The second problem came directly from the first. We had a predictor based upon baseline covariates, but this is a disease with lots of tracking variables. And in particular, we measure the performance, the efficiency of the lung with something called SpO2 FiO2 ratio. And it's available right on as the clinicians are making decisions. And so we wanted to be able to update our predictions from the baseline ones using monitoring data. And so we had a MD PhD student down here in the corner, Shannon Wong-Verbulson, who's just graduating now with her, she's finished her PhD in biomedical engineering 2 years ago, working in biostatistics with us. And then Matt Robinson is I think an associate professor in respiratory medicine. And the two of them have built this tool. And it's basically, the goal was to sort of take tracking data and add it to our predictions. So we want to be able to predict the risk of severe outcome using the baseline variables, but all of the intervening measures that occur along the way. And we update our intervening measures hourly, but we've been updating our predictions every 6 hours. We had already developed, Shannon as part of her PhD had already developed a machine learning tool that could be applied to survival data with time varying covariates, to other kinds of longitudinal data, and to multivariate survival of longitudinal data. And she calls it RF-SLAM for survival longitudinal multivariate. And so she took this tool and got together with Matt, and they have applied this to the COVID problem. The interesting thing is we wanted this to be used by clinicians. And so to give them predictions from a RF-SLAM algorithm didn't sell very well. So she developed the technique of approximating the predictions from the random forest using a single tree. And it turns out with the smoothing that goes on when you fit a random forest or any other machine learning technology, the smoothing that you impose dramatically decreases the degrees of freedom among the predictions relative to the observed data. And so you can get these approximating trees that explain 90–95% of the variation in the predictions from the random forest, but which are also very easy to interpret. So that's the tack that we took, and they created a tool called SCARP for Severe COVID-19 Adaptive Risk Predictor. The interesting thing is this was all done out in our precision medicine analytics platform, which is a cloud-based system. But to get it back into the clinical workflow, we had to put it back in our EPIC EHR, and EPIC does not have the facility to do these kinds of calculations, or at least we didn't have a version of it that did. And there are issues of ownership that still seem to be a problem, but we were able to take a crude approximation to this, and we call it SCARP Lite, and implement it in our EPIC system. So let me just show you the results. We had, I think, 170 variables that we started with the goal of predicting whether a person would become severe in the next day or severe in the next week. And among those 150 predictors, these are the ones that were most important. And I just don't worry about the particular ones, but you can see there were the initial comorbidities, demographic variables, lab variables, and vital signs. And you can see it's almost all vital signs, and they're almost all those things that Brian was showing, the measures of lung efficiency, respiratory rate, and pulse, and fever. And then the labs add predictive power, and so that's important. But the other things turn out not to be important in one day. Some of the demographic variables, and in particular age and BMI, come in to be important in the 1 week prediction. So we make those predictions, and then this is an example of a summary curve that explains something like 95% of the variation of the predictions. And you can see what I was talking about just a minute ago is how there's tremendous variation in the risk. Here's a person with 2% risk over the next 1 week, and up to 60% with risk of severe disease over the next week. And you can see the variables are largely ones having to do with lung function. And these, of course, are not available at baseline. So it's important to have this dynamic system in place. And what we were able to do is put it back into the clinical into EPIC. And I'm going to let Brian describe what the doctors wanted and how they use it.
So this is a screenshot of what you can get in our EPIC system right now. We've obviously hidden patient names, but this is a list of all the patients who are hospitalized with COVID on this particular day on our non-ICU unit. And you can see here on the left column is the 7-day risk of developing severe disease. And in the second column is the 1-day risk of developing severe disease. And so frontline clinicians, if you're covering a busy service, you might have 30 COVID patients and then 20 additional patients on another unit that you have to cover in the middle of the night. At the beginning of your shift, you can come in and actually take a look at this list and understand, all right, these 3 patients are at higher risk of developing severe disease. I might go check in on them even if I don't get called about them. And then our operations managers actually can see how many patients who have COVID or are hospitalized right now are at risk of needing ICU level care. And they can take that into account as we're deciding, do we need to open another ICU? Can we accept these transfers from other hospitals who have critical care needs with or without COVID based on what's happening in the hospital? And so this is happening right now.
And this one is specific to a particular patient. I think that the data is a facility to enter the data on the left if you want, and as you begin to enter the information within the ICUs, it's all updated automatically. This is a version that could be used outside of that setting. And but what I like about this is it shows you the risks of the 1 day and 7 day. But in addition, if you want, you can choose one of those, and it'll show you where this person is in a tree, and you can then understand where the risk has come from. And that's available in the other in the inpatient version, and doctors actually sort of use this as a way to educate themselves about where what's under the hood of this risk prediction. Okay, so let me now go on to the third example, this is really asking, given my current state, so I come in, I have certain features, I'm say 7 days into my stay, what are my future chance of leaving or of needing to be intubated or of death as we go forward? And in each of those, for each of those probabilities, what would my biomarker trajectory look like? So this is meant to be piecing together what we know about predicting a person's risks of events, what we know about the longitudinal nature of the repeated measurements we're taking as we follow people through time, and then piecing that together to be able to make a different kind of prediction. And this is more statistical in nature, it's not as far along, but there's a couple of interesting aspects which I wanted to point out to you. So first, this whole thing is implemented in terms of a Bayesian hierarchical model, and it has three components. The first is what we already talked about, taking the presenting characteristics of the patient and predicting their likelihood of having either severe disease, which would include intubation, of dying, or of being able to be discharged in a healthy state. So those are the three competing risks we want to be able to account for. We have all the baseline covariates, which I talked about. So we're going to build a prediction model. We already built a prediction model using these competing risks going forward. The second component is interesting. It's a multivariate linear mixed model, but we fit it backwards in time. So we define time 0 to be the time that one of these three events occurs, either intubation, discharge, or death. And so that's time 0, the time of the event. So what we're really modeling here is the joint distribution of these measurements we make when they're in the hospital. We're modeling their joint distribution conditioned on what their outcome is. And then with a little bit of algebra, you can show that, and just using Bayes' rule, that if you take these two models and apply Bayes' rule, you can calculate, given a person's presenting condition and given they've been in the hospital for a certain amount of time with a certain set of biomarkers that we've measured, we have joint information about their biomarkers, we can predict forward what their risks of events, of the three different kinds of events, are in each of the future days, and also what their biomarkers are likely to look like. So this is work that's done by a very young MD PhD student, Mary Grace Bowring, and a entering PhD student. She was a master's student, and Zitong Wang, and the two of them took the lead on this. And so let me just quickly show you a picture. They have a paper that's going to appear in, I think, the American Journal of Epidemiology about this retrospective multivariate mixed model. So this is just one variable. We're looking only at SpO2 FiO2 ratio. And this is for all the people who are not vented. They're not intubated yet. What we're taking is time 0 is the time that they have one of three events. Blue, they go home. Green, they become vented, and red, they die. So we call time 0 the time of one of those events, the first event that happens for the person. And now, and what you can see, if I take that out and don't confuse you, is you can see the average pattern of what happens to people who come in. This is for their SpO2 FiO2 ratio. They start up around 500 on average, drop down to 400, a little bit under 400, and then return close to 500 at the time of discharge. So these are all people that are discharged, and you can see their individual curves in blue. The green ones are sort of lost in the blue maze, but you can see the confidence interval here. So this is what happens to people who come in and on day 0 become intubated, right? And then here are the people who come in and on day 0 suffer death. Okay, and then there are the people who get intubated. You can see this green group, they go across and they either get better and go home, or they don't get better and ultimately perish. So we fit a model, a longitudinal data model, it's a multivariate model, not just SpO2 FiO2, but to multiple biomarkers. And we can characterize the joint distribution conditioned on whatever your outcome event is, both pre and post ventilation. So that's that. And now what we're going to do is we're going to take that model, and we're going to take the baseline prediction model. Here I'm showing it on the left. So for a person who shows up with a set of biomarkers, in fact, I'm just going to be looking at 3 biomarkers: SpO2, FiO2 ratio, temperature, and pulse. These are the 3 most important we have found in prediction. And these multivariate models get complicated to fit and become a little bit, we're just about done. For people worry about time, we're getting there. Anyway, we have 3 to start, and you can see a dot here for this person. You can't see that dot, it must be under. And this dot, these are the presenting values for those 3 biomarkers. I think I can't see this one dot. Yeah, so for that biomarker, and based upon those and many other variables we measure about them, we predict that this person has a low probability of dying. This is cumulative probability here on the left. A non-trivial, maybe 12% chance of being intubated, cumulative risk of being intubated, and a cumulative risk of discharge of the rest. There's some small probability they'll still be in the hospital after 15 days. So anyway, these are sort of like, think, baseline predictions of what we're going to see. And you could think of this as like a prior distribution for what we as we go in to start making measurements about the person. Okay, and then the second piece of information comes from that longitudinal data analysis I just showed you the graph from. So we can calculate the likelihood of the set of biomarkers we've seen on the person as a function of the type and day of their outcome, of day 0, their event day, off in the future. We don't know what event day it's going to be, but here we're sitting at day 0, so it could be day 1, day 2, day 3, all the way down to day 15, right? We're going out 15 days in this picture. And this first column is what happens if on day 1 through 15, they're discharged, right? And the second column is what happens if they die, and the third if they're vented. So for each of the possible outcomes and each of the future days, we can calculate the likelihood of having seen this biomarker data. And given the likelihood and the prior, we can calculate the posterior distribution of both their trajectory and their probability of the different events. So the way you read this graph is you see these little circles on the ends of the blue lines. Those circles indicate over here on the left the probability of having that event that's being discharged on that day. So all the blue curves show what we expect the profile to look like if a person is going to, this is the profile for SpO2, FiO2, for temperature and for pulse, what we expect those profiles to look like if they're going to be discharged on day 1, day 2, and so forth. And if they're going to be vented, those are the green ones. And you can see that the dots at the end are very small. So cumulatively, this person has an 84% chance of being discharged given this first day's data, no chance of dying, 16% chance of being vented. Now we can play the movie. So we get updated data every day. This person's SpO2 is falling, that's bad, but their temperature is falling, that's good, and their pulse is staying constant. That's not so great for this person, but it's not so bad. And so these probabilities are changing. The discharge is 85, venting's gone up to 15. Now discharge is going up a little bit. They've turned the corner. They didn't go back. They didn't go down too low on the SpO. They're starting to turn. And now you can see the circles getting bigger in discharge. And also they start to come closer because they're improving, and discharge is getting certain. The other two are very modest. And in order to get discharged, they have to keep getting better on their SpO2, FiO2, and they are. And now we say you're going home. It says 1, but it's not exactly 1. Now we say 1 again, it's not exactly 1, and then they go home. So we can play this little movie for each person using this tool. Okay, Karen, do I have 3 more minutes?
Yes, please.
Okay, so I want to show you one last thing that's that Yizhen Xu, shown up here, a postdoc, is working on, that I'm very excited about, but it's her effort, the group's effort, to try to ask the question, which treatment is best for me now? I mean, until now, we've been trying to communicate to clinicians, what's the patient's state, what's their trajectory, what can we expect going forward? But now we want to ask the question is, which treatment is best for me now? And in particular, we've focused on this question of whether we should intubate today or whether we can delay the intubation a little bit further. So let me just start by saying this is a very hard statistical problem, and statisticians tend to be a suspicious bunch, and so I know a lot of people start thinking, well, is this really possible? Because we want to actually do this for one patient. So let me just give you the flavor of what we're doing. We're very excited about where this is going. We understand there's lots of assumptions, but I keep reminding myself, the clinicians keep reminding us, absent these kinds of tools, they just have to wing it. It's complicated now because they got lots of information, lots of data. The data is flowing. We're helping with making predictions, but it's complicated. And so if we can use models to do what if scenarios, for example, or to help them interpret the data they're seeing, that might be useful. So what we're using here is an entirely Bayesian approach. We're going to have lots of proper priors, and we're going to do built-in sensitivity analysis. But it's basically looking forward in time, prospectively in time, using the data we see on a patient so far, and then trying to make predictions going forward. And what's interesting about this work is we're now going to jointly model the biomarkers given the treatments people are on and given a set of random effects, which are to build in the sensitivity analysis. We're going to model the events that happen given the biomarkers and the treatments and these random effects. But most importantly, we're going to, in real time as an outcome, model the treatment choice that's being considered, given that, and that treatment choice is going to be informed by the biomarkers and the events and also by the random effects. And by allowing these random effects to be correlated with each other, we can build in sensitivity analysis. In the future, we expect that the prior distributions about how the treatments affect the biomarkers on the events, that those will be filled in with strong prior distributions from clinical trials. And that evidence is starting to build. So we're not starting from scratch. We'll be incorporating clinical trials results into these Bayesian models. And I said we built in sensitivity analysis. So just to give you a sense of this, E are the events, and the events are either to be discharged or to go home, to be discharged or to die, or to stay in the hospital. Those are the three possibilities. And Y are the biomarkers, the collection of biomarkers, and A is the treatment. And the idea here is to say that at a given time, each of these things is caused by the other thing, the history of the other things. And we have this feedback system that's operating. And what we're doing is introducing random effects in your likelihood to get vented or not, the random effects that describe your trajectory of the biomarkers, and random effects to describe your tendency to be discharged or to go home. We allow these to be jointly modeled, and they affect the feedback system. So I'm going to jump quickly, but let me just show you what comes out of this. So this is an example of a person's trajectory, actual trajectory for this is the SpO2 FiO2 ratio again. And this is one patient. We've seen them up till day 12. And what we're doing is projecting we simulate 4,000 realizations for this person. A green dot means they went home, a red dot means they died. And then the gray curve shows what their SpO2 FiO2 ratio trajectory was. And this is under the situation that the person was intubated on that day. If we don't intubate the person on that day, what do the trajectories look like? Well, they don't rise in the same way. We don't get very much evidence that people are going home, and there's a lot more deaths. And these multiple panels are for different assumptions about these random effects. And I'm not going to have time to go into that today, but this is like a built-in sensitivity analysis. So we have a number of other, Brian, do you want to jump in, or do you want me just to quickly say that? Well, why don't you finish up?
Sure. So, we'll briefly gloss, it's not just about prediction, right? It's about trying to understand the real world effectiveness of treatments. So for example, we looked at, we used propensity score matching based on the timing that someone received tocilizumab, comparing them to someone who hadn't received tocilizumab. And we were able to show before dexamethasone complicated the issue that treating somebody with tocilizumab using a criteria we had developed at our institution about certain levels of inflammation, certain amount of oxygen requirement. Tocilizumab itself was associated with a mortality benefit, and this was led by Eliza Ignatius, who's an ID physician. Want to skip to the next one, Scott?
Yeah, go ahead.
We also looked at remdesivir. The big Act 1 trial here in the US showed that it decreased time to clinical improvement by about 5 days. But the larger WHO Solidarity trial did not show a mortality benefit. And so there's different practice habits of who gets remdesivir around the world compared to the US. And we looked in our population and showed that remdesivir was associated with a decreased time to clinical improvement. And what was unique about this population in our group was that we had 80% non-white patients, which is in marked contrast to what the original studies had, where it was only about 30% non-white patients. So this provided evidence that there is real-world effectiveness data for remdesivir. And if we go to the next slide, we also can look at treatments like high-flow nasal cannula, which is a way of providing oxygen to try to delay the time to intubation. And we looked at patients who had a really low STEF ratio, who were really sick. And even if they ended up going on a breathing machine, simply going on high-flow nasal cannula decreased their risk of death. And so that has some implications for how to design future trials and the use of high-flow nasal cannula, but also some interesting questions about mechanism of injury from being on a breathing machine. And then finally, we can use this type of data to make to correlate to the pathobiology of disease. So Anthony Rosen, who I mentioned earlier, and his wife Livia Casciolo Rosen, they have partnered together for decades on trying to link the phenotype of a rheumatologic disease with the autoantibody profile in certain patients. And so they asked the question, could some of the patients with severe COVID actually have an autoimmune disease? And they were able to find an autoantibody, an IgM antibody against the ACE2 receptor, which is the receptor that the spike protein on the SARS-CoV-2 virus uses to bind and then enter into human cells. They found that a higher percentage of people with severe disease had this autoantibody. It was not found in other types of autoimmune diseases or lung disease. In a test tube, it activates complement, which is part of the inflammatory and coagulation cascades. And in autopsy studies of people who died from COVID, they found a lot of IgM positivity staining on endothelial linings of different organs, like the kidney, for example. So there's tons of questions that remain. We're actively investigating the use of combination therapy. Remdesivir plus dexamethasone plus tocilizumab. The combinations are becoming increasingly complicated. We're trying to understand the impact of vaccines on who's getting hospitalized and what their disease trajectory would be. And I'd add to that, we're also looking into the variants and how those impact disease. And then there's a huge effort internationally, but hopefully will be funded by the NIH to help lead this, to really understand the risk factors that underlie the post-acute sequelae of COVID. There's a huge group of people that have worked on this. We don't have time to highlight everybody, but just to give you a sense of the breadth and depth, it's School of Medicine, School of Public Health, applied physics, our data scientists, and the precision medicine analytics platform. And I just like to acknowledge on the next slide, lots of people volunteered their time early on. Just as many people were, going to the front lines and going above and beyond. Scott put together an amazing team of people, including Karen and a lot of their grad students and other colleagues who really have volunteered their time by and large to make this happen over the last year. And lots more work to be done. If you're interested, you can see all of the published papers. I put this in the chat, and as did Karen. All the work we showed you that's been published, you can actually get a link to the PubMed citation there. And hopefully there'll be more to come, including some of the analyses that Scott was just talking about.
Thank you so very much, Scott and Brian. And I think I'm going to say, like I usually do for my training program, I understand that people may need to drop off, but I think we can just go on a little bit with questions, as people are available, and Jim can dive in, if I'm wrong. There's a great question in the chat that I want to highlight from Stephanie Vandenberg. And so, as you guys were showing the data visualizations, there was a lot of appreciation. And Stephanie asks, how did you guys decide how to best present risk predictions for frontline clinicians and cohort results for data scientists? Did you have visualization information design experts, or how did that whole choice of the best visualizations to pursue go?
I'd say, Scott and his team had come up with a number of different ways of looking at the data, but then we also had clinicians on our team to look at those visualizations and to really try to think about how would I use this on the front lines. And so Matt Robbins and I are both frontline COVID clinicians, but we actually went to we have a group of clinicians called COVIDists, who are people who have basically dedicated the last year of their clinical life to take care of COVID patients. And so we met with groups across the institution who have kind of self-identified as COVIDists and really helped to understand what is the workflow in the electronic health record and how can we provide you information that you're likely to use. And that's where those columns where you can have a patient list that shows you someone's risk that gets updated hourly. That's where that column idea came from. And that's how we ultimately had this in Epic. And Epic itself actually has a large committee that has to approve any data visualizations and any prediction modeling that goes in. So we also had the input of all the folks who've been working on Epic implementation across Hopkins for the last 5 years to weigh in as well.
As my goal as a statistician to make wild figures, as you saw, and then to let the clinicians tune them down, is something that they can tolerate. So I think the idea of including design experts from the very beginning is important, and increasingly we realize that has to be done.
Wonderful. Robert Schneider asks, how do you handle the virus mutations in your models?
So the short answer is we have not yet. And part of that is just having reliable data on what the genotypes of the virus are. So we have a really talented clinical microbiologist lab led by Hevla Mustafa, who's actually been funded by the state and the CDC to really start sequencing many, many more viruses. So we don't have much information from early on in the pandemic in terms of the virus variants. We're getting more of that information, and we're trying to link that and the biorepository data that other folks have collected to the CROWN data. I will say that does bring up an interesting question about how to deal with how things change over time, right? Because the variants are just one of many variables that have changed over the time of this epidemic. If you look at hospitalization mortality, early on it was about 20% in our hospital. Now it's down to 8%. And I think it would be naive to say that all of that is due to dexamethasone. In fact, it's very unlikely that most of that's due to dexamethasone. It's other things. We've gotten better at taking care of patients in isolation units. We've gotten better at identifying who needs to be intubated. We've gotten better at getting people into gear to get them critical therapies on time. We've gotten more comfortable with bringing in wider groups of consultants to know that we can provide pretty much the same care we provide to any other patient we can provide safely to COVID patients. And that's not something we knew back in March and April. And so that's another wrinkle in terms of how do you deal with these changes in outcomes over time.
Not seeing further questions, I'm going to ask a brief one of my own, which is just for individuals out there who are impressed by the team accomplishments. If you imagine being a data scientist out there with great ideas, but you don't quite know how to get connected to clinical experts or vice versa. Are there any lessons that you have to share with people about creating and maximizing the values of teams like you guys have created?
Well,
Talk to
I would
Scott.
say I would say one thing. People really matter a lot, and we were fortunate to find Brian the very, very early part of this process. Auntie Rosen is a leader. He knows all the people, and he said he appointed Brian made him responsible for this, and when he was responsible for it, he owned it. And so he started holding meetings. He's a critical care medicine person, so he wanted to do them at 6 a.m. We eventually convinced him it would be 7 a.m. and then eventually Karen complained a lot and we moved to 8 o'clock. And so anyway, but the point is the meetings kept showing up every Monday and Thursday on the calendar, and he has a passion for what he's doing, and it made it, it kindled it. And we had 30 or 40 people typically at these meetings, and they're like senior clinicians and junior students and biostatistics, and it's been an amazing education, and students have had the opportunity to learn right at the front lines of this epidemic. So I think my answer to that question is find the right person who's got enthusiasm and the drive, and who wants you to show up early each morning. So That works, Karen.
It's funny, Scott, if I had jumped in first, I would have had the slightly reversed, Anthony said, Brian, I'd like you to do this, but you need to get Scott to organize a team and you need to just do whatever Scott tells you to do and things will be okay. So, I think we've had just an amazing collaboration across the entire health system. And we've also, I think we've benefited from the institution recognizing that this was important and they needed to put time and resources and energy into this effort, recognizing that, we might not see, any results for a few months. And I think Anthony gave us, a 4-month timeline initially. Do what you need to do in 4 months, but make sure you have some results. And that's about how long it took until we had our first prediction model ready to go to share with the wider community.
And so if you guys have another, minute or two to answer
Yeah,
questions,
sure.
so-
I see Shuyu's Fawn's question. I love this question. It's like, what's the big deal? The person was 80 years old and was a diabetic. I could have told you they were at high risk. Well, exactly how much, Shuyu? That's what I would say. It's like you could say they're at high risk, and that's how medicine works. Basically, it's sort of qualitative assessment. But as it turns out, in a lot of areas, if you can move from qualitative to quantitative, especially when you think about population outcomes over the long term, you can really tune decision making and make it better. So I think if it's not burdensome to process the data and it's not burdensome to present it at the right place where it's needed, we think you get better outcomes. But to be more specific, what we're doing now is trying to run clinical trials to show that these tools actually produce better outcomes, not only better predictions.
And then there are two related questions having to do with questions that are related to each other, having to do with the trade-off between accruing more data to make sure that one's findings are stable versus the need for information. So how do you make that trade-off in deciding that now the data are good enough, I can go and communicate to doctors with it, or how do you determine when more data may actually change predictions and how to approach that?
Well, I think we're all living this in real time, right? If you look at the number of press releases that are now coming out and being accepted as, there's actually a medical student, Josh Gray, who's worked with our team. He's actually looked at abstracts as they're published in medRxiv, and then seeing how they change between being in medRxiv and actually being published in the literature, but also looking at how many guidelines are actually citing now non-peer-reviewed publications as well as press releases in order to make decisions about patients with COVID. So I think these are unprecedented times in terms of the speed at which people are getting data out there, but also perhaps acting on data that has not been appropriately vetted. And we've learned some important lessons from that. I think we have been fortunate enough to have a large enough team that we can do internal data checking and model checking within our group. And so when we've gone to publication, we've been confident that we are as best as we can with the methodologies we have, recognizing that there is no real true answer with these models. We can stand by the decisions we made for the statistical modeling, and the inferences that we make are sound and plausible. But I think that we're constantly updating the data. Our registry refreshes on a weekly basis. For certain analyses, we've had to make decisions about when to cut things based on when certain drugs have become approved by the FDA, or when certain therapies are available, when vaccines are available, to recognize kind of shifts in demographics of who's getting sick. And I think it really depends. The answer to that question really depends on what is the question you're trying to answer with the data, and how much is the data being impacted by those changes that are happening in real time.
Yeah, I would add one thought is for the statisticians who don't work in patient care. This was a real lesson for me when I got more involved recently. Writing papers and doing work that can be used in clinical care are entirely separate entities. So clinical care is designed to work where we write papers, clinicians read the papers, and then they decide what they want to do using their best judgment. When you want to actually bring an analysis to bear on a decision, you are entering a new realm, and it's governed much more tightly, legally, There's lots of policy around it. And so the idea of just taking predictions and putting them in front of clinicians, you don't get to do that lightly. And so, and it's very interesting. And it's an area for statisticians to take a look at, for those who haven't had a chance, because it can color how you do research. If you really want your work to be used, you have to be prepared for the translation process that is somewhat onerous.
Well, at this point, I think that I should turn it back over to Jim to close out the session. But Scott, Brian, thank you. I hope you've been looking at the chat and the Q&A for all of the grateful comments. Thank you for a wonderful presentation.
Thank you all.
Karen. Thank you, Scott and Brian, for just an incredible presentation. I'm sure others will want to see this, and I'll just mention that the video recording will be on the NISS.org/news website in another day or two. And again, our thanks to the participants for joining, and again, Karen, for putting this together. Thank you.
Thank you, Karen. Thanks, Jim.
Thanks, everyone.